shall now go on to our next speaker, Dr. QURESH MASKATI, who heads the MASKATI Eye Clinic, is our past president and an amazing person who has taken corneal society of our country to a very different level from long immemorial. So he is going to talk to us on a very interesting topic, chemical burns, which could throw up a lot of controversies. On to you, Doctor.
Thank you.
Yes.
Okay. So we'll quickly go through the modern approach to chemical injury. For paucity of time, we'll talk mainly about acute injuries. We'll go straight to Dua's classification because we've had various classifications. We were all using the Thoft classification and others. But now, once we know about limbal stem cells, we are now using mainly the Dua classification, which was first published, I think, in 2001. So it's about 20 years old. And this is a dynamic classification. So every time we are dealing with the chemical burns, we can classify it as grade 2 or grade 3 or whatever. And with treatment, it might change. It might from 3, it might go to 1, or from 3, it might go to 5. So every time we see the patient, we need to change the classification depending on what we are observing. So that's something to be kept in mind. The prognosis we give is as per the classification. If it is grade 5 or 6, we need to be very guarded in our prognosis. And hopefully, if it's from grade 1 to about grade 3, we're able to restore fairly good vision. Emergency treatment, I'm just stressing a few points. Copious lavage means you need the resident or the eye surgeon concerned to wash the eye for 1 to 2 hours. It is not copious lavage, doesn't mean instead of 10 cc syringe, we use 2 10 cc syringes. So there has to be tremendous amount of lavage or wash because the chemicals tend to stick around over there. And if you see physical, if it's lime, you might see physical lime particles there. You need to remove all of them. You need to double evert and find them and remove them because lime being left behind, we've seen in patients coming after 3 months with still lime in the fornix. So you need to remove this. And if there is necrotic dead material, you need to remove that because the more dead material you have there, the more polymorphonucleoside invasion. So you need to remove all dead material. It's not helping in any way. So if atropine is a must, every patient must receive a drop of atropine with chemical burns. There's no homatropine, there's no cyclopentolate. These are all homeopathic medicines. Topical antibiotics in every case. And I'm extremely fond of 10% vitamin C or ascorbate. Again, there is no dilution involved. If you get injection vitamin C, it is already a 10% solution. Just have to break the ampule, put it in an empty eye drop bottle and dispense. If you don't get injection vitamin C in your area, just take tablet vitamin C, which is 500 milligram, dissolve it in 5 cc of saline, and you can distribute, or 5 cc of distilled water also is fine. 5 cc of some lubricant is also fine. So there's no dilution involved. Again, since the 80s, since I was a resident, we've been using patient's own venous blood, and I'll explain why. So we take the patient's blood from the elbow, the venous blood, and inject it subconjunctivally into the upper and lower fornices as it is seen over here. And if the patient is admitted, if you are in a hospital setup, then at night I pour drop by drop blood on the patient's cornea till a blood clot forms, and then gently close the eyelid at night so as not to dislodge the clot. And in the morning, you can start medicine again. What about steroids? People keep on asking me in chemical burns, sir, how can we use steroids? Of course, you must use steroids. Please understand, if there is no infection, again, I reiterate, if there is no infection, steroids are not contraindicated. There is Kenyon et al. Had proved very well in animal experiments that epithelial mitosis and epithelial sliding to cover a defect takes place better if the underlying stroma is treated with steroids, so that there is the edema is reduced. So steroids in all cases, of course, if there is a melt or an impending melt, or if there is infection, you will not use it. So I told you about the blood clots as well. What about amniotic membrane? Again, we should be proud that a landmark paper of almost 22 years ago by late Dr. M.H. Sridhar and Dr. Rao and Sangwan et al. conclusively proved for the first time to the world that amniotic membrane, which is always used for late chronic chemical burns, can and should be used in acute chemical burns also. After you've cleaned and removed all the necrotic material, it has a very big anti-inflammatory role. Amniotic membrane in a cold case may remain for even 2 months in the eye, but here an amniotic membrane in a hot case like this, in an acute injury, may get absorbed in a few days to a week, but it will tamp down the inflammation quite remarkably. So again, this is something that all of us must use. Systemic treatment is the usual. I won't dwell into the details. Sedatives if the patient is in a lot of pain, and ascorbic acid or vitamin C by mouth or intravenously can be given. At least 2 grams per day should be given for at least a month. Why am I stressing so much on vitamin C? Because it reduces the incidence of ulcers and perforations. How does it do it? It's required by fibroblasts to make collagen. So this is not a new finding. This is from in the IOVS at ARVO. It has been shown time and again. Right from 76 onwards, there have been papers. I dug out some of the papers. And so vitamin C, which is so cheap, so easily available, and so little used in chemical burns, I request all of you to make it part of our armamentarium. Why am I talking about blood? Blood is a buffer. It dilutes the chemicals. It separates tissues. It's a fibrinolytic. It prevents symblepharon formation. So it has multiple uses of the blood. It contains anti-proteases, which inhibits collagenase. As you know, the young collagen, which is being, the surface is trying to repair and form collagen, it is broken down by collagenase. So if you have some anti-proteases and anti-collagenase, it will destroy the collagenase and help the enzymes, help the collagen to grow. And the platelets, which change their shape completely, and they become pseudopodal, and they develop pseudopods like amoebae, and they hold on to the collagen like the dog and cat that you see there, and prevent it from being broken down, and they fill up all the gaps in the denuded surface. There are newer treatment modalities. Doxycycline is something which all corneal surgeons love because it reduces melt. So it should be given in every chemical burns as well. And we talked a little about the lovely role of tenons to reduce ischemia. You can do a tenoplasty. That means take it along with blood vessels and bring it to the area so that it brings blood vessels in at the same time. Some new therapies from chiefly from Iran that they have come. And again, this has been there since about 10 years now, where simple oxygen, we are familiar with use of oxygen during our COVID pandemic that we had. So I urge you, those of you who are in a hospital setup, to use oxygen. It is such a simple thing with such dramatic results in chemical burns. And they used this for, they divided patients with grade 3 and 4 injuries. Half of them received oxygen, half of them did not. And the oxygen group showed increased corneal transparency, decreased vascularization, better visual acuity. And all it needs is a simple mask. So just like you have been giving in COVID, a simple mask with a flow rate of just 10 liters per minute for an hour twice a day. If the patient is hospitalized, a simple mask, oxygen 1 hour twice a day is sufficient, and there is dramatic results. A visual rehabilitation stage, as I said, due to paucity of time, we won't talk about it, but stem cell transplants are the way to go in a chronic case. And as Sushmita said, SLET is what we all use after learning from Dr. Sangwan. In fact, I can't even believe that it is just about 6 or 7 years old that he taught us this, because it seems that we've been doing it for such a long time. If SLET cannot be done with bilateral, there are other regimes, CLET and COMET as well. So this is Dr. Sangwan's series, which he presented in the AAO. I can't better that with my own pictures, so I'm just showing you his and the remarkable results that he got in 125 cases. Thank you for your attention. Sorry if I've overloaded your brain with too much information and caused you to remain awake. But the good news is that I have actually finished. Thank you so much.
Thank you so much, Dr. Maskati. I was truly unlucky to hear your talk because of a very bad network issue at my end. So maybe my questions are going to be sort of irrelevant to what you spoke. But I'll just ask one basic question before I ask Shreya to take on. When would you consider an AMG in an early chemical injury?
Sorry.
I don't know whether it's covered. When would you consider using it? When would you consider using
amniotic membrane
graft.
Oh,
Quresh.
amniotic membrane.
membrane.
Yes, of course. I would consider it almost every patient of chemical injury, except the grade 1, grade 2 patients, where you know that you're going to get a good result with the other treatments.
Yeah.
But otherwise, there's absolutely no harm if you can clean up the tissue and patient is willing to come into the theater. Not all patients are willing to come into the theater, but I would definitely use this, and I'm finding that it really reduces the inflammation quite a bit. Sometimes I've used it even twice. 10 days later, I've put it again.
Dr. Ashish, there's some controversy on this, right? About using AMG. Now, latest.
Yeah, I think there are two schools of thought. One is, shall I speak?
Yes, yes.
Yes.
I think there are two schools of thought. One is because AMG shows such fantastic results, and
Yes,
it probably
yes.
is the only thing which we can easily procure and do in chemical injuries.
Yeah.
That it has a low threshold for most people. But having said that, I think there are certain injuries, especially acid injuries, and even minor alkali injuries or thermal injuries. If you like, I would like to see them in 2 days, start the steroids, do the lavage, and see the epithelialization. If they don't have much of a conjunctival damage, some of them may heal, as Dr. Maskati pointed out. Sometimes they may go from grade 3 to grade 1 within 2 days or 3 days,
Yes.
especially children. So I think
Yeah.
that is what we kind of keep in mind based on
Yeah.
the situation. I think, Sushmita, any points to add?
I think, yeah, I'd agree with what Ashish said. Even my threshold for amniotic membrane grafting is pretty low. And because what we have seen clinically is, even if with the steroids and other things, the surface inflammation subsides and the surface epithelializes, when in subsequently, say after 6 months, when we're trying to do the slit, we find that in eyes where we had done a AMG, we can very beautifully peel off all the pannus and symblepharon and do the slit very well. The underlying tissue is much less scarred. So versus those eyes in which we've only treated with steroids and maybe not done an amniotic membrane, there is a lot of scarring. We have a lot of problem in dissecting the pannus, resulting in a very rough underlying surface. And of course, the slit outcomes also are marginally, not as good as those eyes where an amniotic membrane had been done in the primary stage. So I very strongly recommend an amniotic membrane. Anything more than grade 2 injuries, I usually
Can you please mute
do an
yourself,
amniotic membrane.
everybody? Please mute yourself so that we don't get background noise. We should all be realizing that. Yes, good answers. I mean, we have two types of two considerations. Yes, Dr. Shakeen. Yes, Dr. Shakeen. Yes.
Good evening, Dr. Ma'am Chitra. I'm sorry I was late to join. One point I just want to ask Dr. QURESH about conformer and BCL to be given immediately after this first state of a chemical burn to avoid symblepharon. What does it say about this?
Yes. Again, if you're putting in an amniotic membrane, we find the incidence of symblepharon is reduced, but absolutely no harm. I'm very fond of both the ring conformers as well as the large conformers to prevent symblepharon. And when a patient is not close to you and you're not going to see the patient often enough, putting in a ring conformer or a full conformer is a safety valve that you have.
Yes.
Thank you.
Yes, Dr. Shreya.
The conformer question I was going to ask already answered by Dr. Maskati. And if it is at all not healing it, so what is your experience of PK for this chemical burn, penetrating kinetoplasty?
Not in the acute phase. Whatever it is.
Yeah. But what is your experience?
Sometimes you're pleasantly surprised, and at the end of it, if you're evaluating the patient you need to evaluate whether you really need to do a PK. Nowadays, with our preference for DALC, our incidence of doing PK has gone down. So if there has been no perforation of the cornea, no melts, and then you assume that the endothelium is okay, and as Sushmita is fond of, do an OCT and check everything. I would go for a DALC if I have to, but I would prefer first to do SNET and stabilize the surface, and then if I have to, I would do a DALC rather than a PK.
I think I just
Yes, doctor.
I'll just make one point here that in tuna injuries, sometimes the deposits are very deep. So I think, as Dr. Maskati pointed out, I think in those cases, you are almost doing a very deep dissection to remove as much as possible. So in those dissections, you should have a backup tissue, because sometimes you may, so that those are the only times when we may kind of think of a therapeutic PK, generally speaking, not as a planned approach in acute stage.
Yes.
Quresh, just one point
Sorry.
regarding the role of tarsorrhaphy in some of these cases where nothing else is helping in healing. Sometimes a little lowly tarsorrhaphy helps in a good deal of healing. What do you feel about that?
Yes, absolutely agree, sir. Yeah, we have had cases wherein patients have come with perforation, so there is no there's no choice but to do a penetrating keratoplasty. But having said that, we know when the limbus is completely damaged because of the chemical, the graft is not going to survive. So we do a PK is more of a tectonic keratoplasty, and we close the lids with a tarsorrhaphy. Sometimes we even do a central tarsorrhaphy and close the lid. We expect the surface inflammation to heal, and and then maybe after a year or so we can open up the entire surface, release all the symblepharon, and then do a surface reconstruction with limbal biopsy, with a limbal graft and conjunctival autograft and things like that. But yes, tarsorrhaphy is, I think, priceless in these situations to avoid exposure, avoid melt, etc. It's very good point, sir.
The trophic element.
Yes, sir.
Yes.